Blog Talk Radio.
Ladies, let me talk to you about mastectomy. Losing a breast or breasts is not the end. Naturally, you are all still capable and very sexy. I know this because it happened to me. I want to tell you, woman, what's the real deal. You see, the surgery doesn't diminish your sex appeal. The secret is in your attitude. Don't let folks ruin your day when they are rude. You are a much better than you used to be. Take a look in the mirror, and you will see. Mastectomy was never a part of your plan, but fate dealt you this rotten hand. Claim it, deal with it, and then quickly move on. You see, there is no need to set up camp in the eye of the storm. It's the only way the battle will be won. In the aftermath, a new outlook will be born. Ladies, know that you didn't fail the test when the surgeon removed your breast or breasts. Life serves lemons. You make the best damn lemonade. You serve it with confidence and don't be afraid. Don't fear what life now has to offer. There is no need to be scared, and there is no need to suffer. Have a beauty contest, be the best you can be. Swimsuits or evening gown, you are still sexy. Know that you can, and you certainly will. You grab a handful of life, and ladies, have your fill. That's right. You grab that handful of life, and you have your fill. Well, hello, good evening, and thank you very much. I know I haven't been here for about a month, and I apologize for that, but you say, hell, I want to thank you, for tuning in. I know that you have a busy schedule, so, you've taken the time to spend some time here on Blog Talk with us, and whether you're in the archives or listening on iTunes, Twitter, MySpace, Facebook, Zango, wherever you're listening, I want to thank you for tuning in. Today is the 7th of February, 2009, and I know it's cold outside. Don't really know what the temperature is, but I know it's cold. I know it's not as cool. I think it's supposed to be 57 degrees, around that, somewhere in the 50s, but you're listening to Blog Talk Radio, and I am your host, DeLeon. I cannot get onto the switchboard for the life of me, so I don't know if my guest is here, but I have a guest this evening, Dr. I don't know if he pronounces it Minus or Minus, but Chrysopoulo. Chrysopoulo. Sorry. Don't know what's going on here on Blog Talk, but I am going to keep trying and see what happens. I don't know if Travis is here, on either. But in the meantime, I want to, if I'll give you a little background on our doctor. He's a board-certified breast reconstruction surgeon, because tonight we are talking about reconstruction, breast reconstruction. And, I don't know what's going on with Blog Talk tonight. He has been practicing medicine since 1996, was raised and educated in London, England. He's a graduate of the University of London, where he received his Bachelor of Science in Advanced Anatomy and Morphology prior to completing his medical degree. He has a very distinguished career. He was also recently named a recipient of the San Antonio Business Journal, the Top 40 Under 40 Award. So he's a very young man also. He was also recently featured on Ken 5 News for using new technology to optimize breast reconstruction surgery. So he comes fully loaded. As part of his dedication to the medical profession, Dr. Chrysopoulo has held special appointments to the National Board of Medical Examiners, and as a clinician, as a clinical assistant, professor with the University of Wisconsin Plastic and Reconstructive Surgery Division. He is certified by the American Board of Plastic Surgery. So we are getting us someone here who, can give us a lot of information, because after mastectomy, when you're going through surgery, or even if you just decide to have cosmetic surgery, there are lots of questions that you need answered. Oh, here we are on the board now. We are up and running. And without further ado, I've told you all about Doctor, and he's going to tell me what how his name is pronounced. But hi, Doctor. You are on the air. Good evening, and thank you for joining us here on the Leon Dialogue.
Thank you very much for the invitation. I appreciate it.
Oh, you're more than welcome. I mean, you come very distinguished, and I am so thankful that you came, because I am a breast cancer survivor, and my right breast was removed, and I didn't rebuild. And one of the reasons why I didn't rebuild is that I don't think that I have gotten enough information. It sort of, was something that bothered me, that I was just given notes and not really got into it. And there are lots of questions that, folks have about Reconstruction, and I would love for you to, give us some information, because I was reading up. I went onto your site, and I was reading up on the different flaps, the DIEP flap procedure, and there are a whole lot of information. So could you kind of, what are the flaps there are? There are lots of them. So, Doctor, could you please, give us a little insight?
Yeah, sure, of course. Well, first of all, the problems you've had with information, unfortunately, I would say that's very, very common, if not the norm. Only about 17% of women diagnosed with breast cancer, when they leave the breast surgeon's office, have even heard the word Reconstruction. So, and that's in the U.S. So, unfortunately, that problem is very, very widespread. We see women all the time that come to the office and say, if only I had known, that I had these options. So that's one travesty. Now, of course, Reconstruction isn't for everyone, but our goal is to definitely get the message out there, so that people that do feel it is for them certainly have the option. If you decide on Reconstruction, you can do it at the same time as the mastectomy, which is very nice, because you wake up with a new breast in place. So many women go through a lot of psychosocial problems, as you would expect, waking up without a breast, and that can be avoided if there aren't any health issues that would preclude a long surgery. That's an option. If there are other health issues, or if the cancer is very advanced and Reconstruction isn't the best way to go initially, you can always do it later. So that's kind of a general comment. And then if you do decide to have it, you've got lots of options. Our practice offers the full gamut of procedures, from implants to using your own tissue. And as you said, looking at our site, we have lots of tissue options, or flaps as they're called, and they can come from different parts of your body. You can use the lower tummy region. You can use the upper thigh, the upper inner thigh. You can use the buttock. You can use the back. And all those options have different pros and cons. And other than using your own tissue, you can also use tissue expanders and implants, and they have their own issues. The main thing is that with using your own tissue, it's a bigger procedure initially, but you kind of pay for it up front, as it were, because it's a bigger procedure. But once you're done, and if it's successful, and the vast majority of times everything is successful, then you've kind of put in, you've put in the hard work up front, you've paid your dues, as it were, and then this tissue has recreated a natural, warm, soft breast that will carry on aging with you. So once you're done, you're kind of done. Implants are easier initially. The surgery is much easier to get through. The results, generally speaking, are not as natural, and there are long-term problems. About 40% of women will need further surgery within 10 years because of problems from the implants.
Yeah, only recently I heard that. It's funny, because I met someone, I was talking to someone who had the implants, and she was saying in 10 years she'll have to redo it or something of that nature. But one of the things that I was told when I did, query it, was that I didn't have enough stomach fat. I didn't want to get the implants. I wanted them to use my own body. But and this is one time when being a small person worked against me, because I was told that I didn't have enough body, like stomach fat, to do the implants. So then he was talking about doing it from my buttock.
Yeah, you can do it from your buttock, and you can do it from the upper part of your inner thigh. So you get a thigh lift at the same time. So with the tummy procedure, you get a tummy tuck. With the thigh procedure, you get a thigh lift. Now, what I will say is, when people talk about the tummy procedure, the traditional operation is called a tram.
Yeah.
The tram flap. That tummy procedure takes the same tissue that is removed during a tummy tuck, but it also sacrifices part or all of one of your stomach muscles. So if you're having one breast reconstructed, you're going to lose the function of one of your sit-up muscles. If you're having both breasts reconstructed, you're going to lose both your sit-up muscles. So that's a big hit in terms of abdominal function. So that's the tram. We don't do the tram. We do something called the DIEP, as you saw on the website, the DIEP flap. And that's basically using the same tummy tuck tissue, the skin and fat, but all the muscles are left behind. So it's become a very popular procedure because, these days, breast cancer doesn't care about your age. Breast cancer doesn't care about your level of activity. And breast cancer sure as hell doesn't care about economic times. So we're seeing more and more of it. And we're seeing younger and younger women, and these women are typically, they've done nothing wrong, healthy women, healthy lifestyles. We've had triathletes, we've had marathon runners, as well as your average, person who doesn't have a very active lifestyle. But for those, for many women, they want to be able to maintain their level of activity. So not losing the stomach muscle is a big deal. Now, unfortunately, with all tissue, when you move it from another part of the body and transplant it up to the chest, it's got to have a blood supply. Blood's got to flow in, and blood's got to flow out of this tissue of the new breast so it stays alive and warm and soft and what have you. So when you leave all the muscle behind, this tissue, the lower abdominal tissue, is removed completely from the body, so it's detached, and then it's reattached to the chest using microsurgery. Now, the problem with that is twofold. Number one, not many people, in terms of plastic surgeons, know how to do it, or have the experience to do it well. And the other major issue is there's no impetus for them to learn because the reimbursement is so terrible. So they can't afford to do it. So when the average breast cancer patient goes in to their plastic surgeon's office to talk about their breast reconstruction options, a lot of the time, things like the DIEP that we just talked about from the lower tummy, procedures like the tug, which is using the upper inner thigh, the gap, which is using the buttock, all those procedures don't even come on the radar. Wow. Because they're not offered because the plastic surgeon doesn't do it, and he doesn't do it because those surgeries take many, many hours. And they don't reimburse very well. So you can't spend many, many hours in the operating room if you can't afford to pay your office overhead. Right. So they would much rather just put an implant in and get paid the same amount of money, and they can do 4 or 5 implants in the same amount of time as it takes them to do one of these big microsurgical procedures.
Okay.
So it's a bit of it's a travesty. But unfortunately, it's reality. So most women listening to this show tonight if they're thinking about reconstruction, if they've had mastectomy in the past, or if unfortunately they're going through the diagnosis right now and trying to decide whether they're going to have reconstruction at the same time, they could go in on Monday to their local plastic surgeon's office, and 9 times out of 10, none of these procedures will be mentioned.
Oh, really?
So, thank God for the internet.
Oh, thank God for real.
Because quite honestly,
that's how I found you.
Yeah, that's how we found each other, exactly. And we get people coming to us from out of state all the time. Our internet business is getting bigger and bigger in terms of our patient. It's incredible. They're finding us online, and they're realizing that not many people do what we do. And then, of course, once you find someone that does it, the next question is, well, who's going to pay for it? And,
right. Is it?
And then, we're one of, I think, 2 or 3 practices in the country that take insurance, which is why people are willing to spend a couple of $100 to get on a plane to come down here, because compared to the out-of-pocket expenses they're going to have even if they do find someone that does do the procedure more locally, it's still a lot cheaper to come to us because we take insurance. So the insurance issue is a big issue, and we're kind of, watch this space, as it were, with, President Obama and the changes and stuff that are being talked about in the healthcare system. We're praying that, some ruling doesn't come out or something that makes it even harder for us to offer this to.
Oh, I hope not. I hope not. Because
I tell you what, if it does happen, I'm going to be on the phone to you to send out a plea to get all your breast cancer patients who listen to your show to write to their senators.
Right, because I lobby.
Yeah, excellent.
I lobby in Washington every September. We to get funds and whatnot, and to institute new laws and different things that is going to help people who need it with health issues. Because I know how difficult it was, for myself. So in any way that I can help, someone else, finding the right person, getting someone to really, speak to you as opposed to just handing you a bunch of literature or speaking to you in terminology that, because when you hear you have cancer and you're going to lose your breast, it's such a traumatic, news.
And then not to mention, sorry to interrupt, but then not to mention, how many doctors do you end up seeing? You're just bouncing from office to office.
There you go, yes.
How are you supposed to remember everything? And then, you're dealing with this shock out of the, clear blue sky that's hit you like a sledgehammer.
Yeah.
And then all of a sudden, now you're supposed to consider options for reconstruction. It's a nightmare. And
it's not only that; it's that they're not speaking to you in layman's terms, so to speak.
Right.
So the lingo is totally out of the medical jargon. I had to tell a doctor, listen, talk to me in layman's terms, because I have no idea what you're saying. It's all sounding like glob to me. The words are all merging because you're spaced out. You sort of having an out of body experience.
Yeah.
And hearing that news, with all the terminology and the flaps and the this and the expanders and you're going, what? You can't even.
Well, here's a good phrase that works. It's talk to me like I'm a 3-year-old.
Yeah, that's like that.
Like I'm a 3-year-old. That works well. So.
May I ask you something about silicone? Is the silicone implants, is that dangerous? Or is it better than, let's say, the saline?
Well, here's the thing about silicone. Silicone implants were taken off the market, as you know, for cosmetic procedures for a while. We were still allowed to use them in breast reconstruction patients, but we weren't allowed to use them in cosmetic patients, which should tell you something off the bat.
Yeah.
Silicone implants have changed. The ones that we're using now and the ones that we've been using for the last 10 years are completely different to the ones that we used
like 20 years ago?
Yeah, when the initial kind of scare came out and the initial so-called problems were reported. Just to tell you a little bit about each implant, whether you choose saline or silicone, the outside of the implant is the same. It's still silicone. So anyone choosing a saline implant needs to know they are still getting a silicone product.
Wow, it's a good thing I asked that because I didn't know.
Yeah, it's just the outside. The outside shell is still silicone.
It's silicone, so the inside is just the saline, but the outside is still the same silicone. So
exactly, the outside shell. I mean, they're a little. It's essentially the same.
It's silicone, by the way. It's silicone and saline.
Right. It's just the filling. So the silicone implant, the word silicone describes the filling. And the saline implant, the same thing. It's the filling that's the saline. But the outside is still silicone. Now, the old implants 20 years or plus, if you sliced the implant in half, then the silicone inside was really thin and kind of gooey, and it would drip to the floor. And also the shell on the outside was really, really thin. So if you put these old silicone implants on a piece of tissue paper, and you left it there for a couple of minutes, went off, made a cup of tea, came back, lifted the implant up, and took a look at the piece of paper, you'd see this oily stain because the shell was so thin that you'd have seepage of the silicone.
Oh, wow.
Yeah. So the new ones, you can do whatever. There's no seepage whatsoever. You can grab them, you can put them on a piece of tissue paper, what have you. There's no seepage. You don't get that same oily residue. And also, if you slice them in half, the silicone isn't as gooey. It's not as liquidy. It's more cohesive. And by cohesive, I mean it's thicker. It's more like a gummy bear.
Okay.
So it doesn't,
Jello type thing.
Sorry.
Or like Jello.
Yeah, exactly. Yeah. Not quite as thick as Jello. So if you slice the implant and then kind of point it to the floor, the silicone isn't going to drip down towards the floor, So it's a lot firmer, but it still feels very soft when it's in the breast. Mm-hmm. So they did a bunch of studies, multiple centers all over the country, looking at thousands and thousands of women, and there was no scientific evidence in any of those that linked silicone implants to any of the complaints. Now, what were the complaints? Some of the complaints were a higher rate of breast cancer, a higher rate of autoimmune diseases, rheumatologic diseases, things like fibromyalgia, lupus, those sorts of things. And none of those bore out, none of those were shown to be the case in these studies. So, and the other interesting thing is that this was geographic. This was only the U.S. The rest of the world carried on using the implants and didn't have these issues. So, you got to ask yourself, what was the real situation here? And certainly from a scientific standpoint, there's nothing to show that silicone implants are any worse for you than saline implants. It's still an implant. It's still a foreign object. It's not a natural thing. So you can still develop problems from a silicone implant just like you can from a saline implant. You can develop scar tissue around it, and you can develop, that scar tissue can become quite firm, and we call that capsular contracture, where the implant kind of gets squeezed by this shell of scar tissue that the body forms around it, and it can deform the look of the breast, and it can even cause discomfort and pain. You can get that with both saline and silicone. Implants rupture, implants can get infected. All these things can happen, but silicone implants are really no worse for you than saline implants.
Okay, so may I ask a question? Let's suppose you're getting what's needed from some other part of your body, let's say from your stomach or your buttocks or your inner thighs or what have you, to rebuild the breast. Can cancer return to those breasts, and if it does, will it be easier? Or will you have more problems identifying the cancer?
That's a great question. Breast cancer can return whether you have reconstruction or not. and the rate of return is the same whether you have reconstruction or not.
Okay. So you're saying to me that the breast that was removed, if you replace it, it can come back. The cancer can come back in that breast that's replaced.
Yes and no. Yes, it can come back, but it's not coming back in the tissue that's moved into the new breast.
Okay.
So, for example, if you use your lower tummy skin and fat and move that up to the breast, and then you get another breast cancer, it's not in the tissue that was moved. It's usually either deep on the chest muscle or under the skin.
Okay. All right.
But it's not actually the tissue that you move to recreate.
In other words, it's safe to say that it probably was there all along, just hidden, just...
Well, it can... If it was there all along, then typically, you notice it a lot sooner. But there are women that have recurrence, that have a breast cancer come back, 10, 20 years after their mastectomy.
Okay, another question I wanted to ask. Can your body reject the tissue that you take from another part, or what you get from and I can't think of the word. I'm the little chemo brain. So getting stuff, some tissue from your butt to put in your breast.
No, it doesn't.
Can your breast reject, the muscles or whatever else that you may move?
No, it doesn't reject it. It's your own part of your body. So if that part of your body is moved, it's still part of your body. So whether it's fat in your belly or fat and muscle from the upper part of your inner thigh or fat from your buttock, just because you've moved it, it doesn't mean that the body's going to reject it. Now, some people, about 1% of the time, when you move this tissue and reattach it microsurgically, up to 1% of people, they don't do well and the tissue develops a problem. There's a problem with the microsurgery or some other issue, and then the tissue needs to be removed because it doesn't survive. And people wrongly say, "Oh, my body rejected my tissue," and that's not the case. For whatever reason, it just didn't work. But that's not rejection. It just means that
it didn't work.
It just didn't work, and that's it depends where you go. But most centers of excellence, the failure rate is less than 1%.
Oh, that's great.
Yeah. Well, if someone said you're going to win the lottery, you had 99% of winning the lottery, you'd buy the ticket, right?
True, most definitely.
So,
I wanted to ask about the nipple reconstruction.
Yeah.
Is that tattooed on, or is there some way that you can build it to actually look like the nipple?
Yes. We use the patient's own tissue. After we've moved the tissue up to the breast, at another stage, it's another procedure, but we basically rearrange some of the tissue that we've moved up to recreate the new breast and the new areola. We basically recreate the nipple by moving some of that tissue around. And then once you're healed and everything looks okay, typically we wait about 3 months for things to really settle. Then we do the tattooing, and that adds the color for the new areola. There are lots of different procedures for recreating a nipple and an areola. They've described using skin grafts from the inner thigh, or using actually even women's labia to recreate that. All sorts of things. There are hundreds of ways of recreating a nipple, but we just like to keep things simple, and we like to use the tissue that's already there, and the results are very good. Now, the sensation to the area is never going to be what Mother Nature gave you.
I was just about to ask you about about
in
the breast.
and I've got to say, when I tell my patients this beforehand, they say, it's a 50-50 split from what I can tell. Some women roll their eyes and say, "Oh, I don't care. I haven't had sensation since my third child," or whatever, or "I've never had sensation." But for other women, it's really important. And here they are, having lived with a flat chest for a while, and now they're looking at a reconstruction, and then, as a man explaining this, for me, when I first started doing this, it didn't add up. You're going from nothing, you were recreating a new breast, and now there's this look of concern because I'm telling you that you're not going to have the same sensation, and
you're going from 0 to 32, or from 32 to.
But for some people, it's important, and there's no right or wrong answer. It's just what's important for the individual. Now, we do, when we move tissue around, sometimes you can find a nerve that's supplying that tissue. Like, for example, if during the DIEP flap, using the lower tummy tissue, we can usually find a nice nerve that's actually going into that tissue that we're going to move, and we preserve that and take it with the tissue, and then we hook that nerve up, we reconnect it to the nerves in the chest, and that helps optimize the sensation. It kind of makes the best scenario.
Bad situation.
Yeah, so, but even then, it's not going to be what Mother Nature gave you. But initially the breasts may not feel part of you, but within a very short period of time, they feel part of you. It's not like an implant that kind of, for some women, doesn't feel part of them.
Surgeons absolutely fascinate me with the things that you all can do when you reconnect and connect. I guess it's like doing electricity in a certain sense, connecting the wires and what. I'm absolutely fascinated by surgeons, and it sounds so matter of fact. Well, this is what you do, and this is the way you can. It's your craft, it's your job, and I was really impressed with all of the accolades and all of the different awards and all that you do. I really am.
Thank you.
And to be so young, to have accomplished so much, that's excellent.
I don't feel that young after these cases sometimes.
And I'm telling you, I still have one breast. I live with one breast right now, and I've always my whole thing is to find when I choose to rebuild the right person, and all of the people, the doctors, I'm not saying that they were bad, but it's just that it didn't. And before I even met you, talk to you tonight, I had this feeling like, I think I will do this. You actually are the first person that have made me think about doing it.
Well,
what are the possibilities? Because I had totally thrown that to the back. I had said if I didn't get it done, the same time that I had it removed, later I wasn't going to do it anymore. Mm-hmm. And it doesn't really bother. It doesn't bother me, to be quite honest with you. And I'm kind of the shameless type of woman. I think I'm sexy no matter what.
Good for you.
So that's just me, people say I'm full of myself. I say I'm full of self-confidence. I think I got it going on, and I'm more than my breast. But the thing, but I'm saying that there are certain things that bother me, and it's not about my pride. It's about discomfort as far as the itching and that uncomfortable feeling. You can't fix the prosthesis quite right. It doesn't sit quite right, and from that standpoint, I am seriously thinking of doing it. And I wanted to also ask, how long does this procedure take? How many days will the average person be in hospital?
Well, if you have one of these microsurgical procedures that we've talked about today, you're looking at 3 or 4 days in the hospital after the procedure. For one breast, you typically stay 3 days after the surgery. And then that's the first stage. That's just the first stage is just moving the tissue up to the chest. We don't really focus too much on the aesthetics for the first stage. The cosmetics is secondary. We just want things to work out. It's a long surgery. For one breast, you're looking between 3.5 and 5 hours. We just want things to work.
That's the part that scares me, is the amount of hours.
Well, the good thing is that during that time, you're on some beach somewhere and someone's fanning you down and bringing you alcohol. You're enjoying the view while we're slaving away. But
I like the way you put that.
And then about 3 months later, you have the second procedure, and that's typically done as an outpatient. Again, it involves a general anesthetic, just like the first time, so you're put to sleep, but it's much shorter in terms of the length of the procedure. And that's when we make you look as good as we can. We touch up your scars, we work on the shape of the new breast. Sometimes we have to do some work on the other breast, a lift or a reduction or something to basically make you as symmetric as possible.
Make you both perky.
Yeah, why not, you know? It's every woman's prerogative to have perky breasts, you know, why not? And then work on the scar, you know, if you have the tummy procedure or the thigh or the buttock, it doesn't matter, you know, wherever we take the tissue from, we just touch up the scar, whatever's needed. Do the nipple reconstruction. That's typically do that at the second stage too. And then that's all the surgery. Then the last phase is the tattooing, and that's in the office under a local anesthetic. You know, listening to the radio station of your choice.
Okay.
So,
maintenance, as far as you know, I know that with the saline and the silicone, in 10 years, will you have to come back to do any, like, you know, booster shots or booster fillings?
The thing about implants is that, you know, this 10-year thing that you've been hearing about, the implant companies basically give you a 10-year warranty or a 10-year lifespan. They basically recommend that you change the implant after 10 years. To be honest, it's a cover your rear end sort of thing. There are plenty of women out there that have had implants for longer than 10 years that are just fine. You know, if it looks fine, it feels fine, you're not having any problems, there's no reason, in my opinion, for you to go in and sign up for extra surgery just to pop in the latest implant.
Oh, okay.
So it depends on your situation, but there in reconstruction patients and women that have had reconstruction with implants, you know, they're not the same as women that have breast implants for augmentation, you know, just because they want to be bigger. The risks of needing more surgery are much higher in a reconstruction patient because they have far less padding over the implants. If a lady just wants to be bigger and she goes in to see her cosmetic plastic surgeon and gets breast implants, even if she's really small to begin with, she still has more than just skin and a little bit of fat. You know, she's got something there, and that extra padding makes all the difference in terms of long-term complications. If you're a reconstruction patient, typically you don't have much tissue left. So we put the implants under the chest muscle to give people more padding, but we still see a much higher rate. A lot more women in that group end up getting that scar capsule that I talked about, the scar contracture. And in my experience, I tell my patients, you've got a 40% risk of having to go back within 10 years for more surgery.
Well, I just want to take a minute to say hi and welcome Travis, our co-host. The co-host is here. Travis.
Hey, Dillion, how you doing? And how are you doing today, Dr. Minus?
I'm great, thanks. Good to meet you.
Are you Minus or Minus?
It's Minas.
Minas.
Sorry, Dr. Minus. I'm so sorry about that.
That's okay.
I love your name. It's original.
Oh, thanks. I think my parents did a good job.
Oh, yes, they did. Especially in educating you. You know?
I think they're still paying for it. Yeah.
I mean, you know, your accolades, you know, it's like a flag. All the different accolades that you have, it's wonderful. I mean, you know, I was really impressed. And like I said, you have me thinking of actually doing it, you know.
Well, come down, pay us a visit. San Antonio is lovely.
You know, so we talked about, you know, he's been, you know, Doc has been telling us all about the different types of surgery. Well, our co-host is, she's a cervical cancer survivor, you know.
Yes.
I'm the one with, you know, I'm the breast, you know. So I wanted to ask you, like,
Can I say one thing about the implants before I forget?
Oh.
Which I think is really important in terms of reconstruction patients. There are there's a big debate, and it's been going on for a long time, about doing a reconstruction using implants in breast cancer patients that have had radiation. Mm-hmm. And there are plenty of studies out there that have shown, and many of these studies are from very reputable centers of excellence. And some of these studies basically say that doing implant reconstructions in women with radiation is perfectly okay, and they all do fine.
Oh, good.
But
add radiation.
That's excellent.
But I've got to say, in our practice, we really try and steer women pretty strongly away from that, because a lot of the patients we get for these tissue reconstructions that we've mentioned, a lot of them have had radiation, and then they tried to go the implant route in terms of reconstruction, and they just get into all sorts of trouble. So it's just all I'm saying. I'm not saying don't do it.
Right.
You got to pick what's right for the individual.
I want to know what's right, because I'll be honest with you. It is not that important for me to get the breast, my breast, reconstructed. Right. But I read your accolades and I saw what you all were doing. It's something that I was like, okay, let me, I'll think about it. But I want to get, and that's the reason why, I'm so happy that I found you. I'm so, I really am thankful that I found you, because you are informed, and you can, I would love, I'm thankful that you're telling me that, because I had radiation. I had 8 weeks of radiation.
Okay.
Mm-hmm.
So if it would be better for me not to, it is not a problem for me. Trust me on that one.
Wow.
Yeah, I've got to say, and let me just say again, plenty of plastic surgeons would disagree with me and would say, oh, I do implants in radiated people all the time, and I disagree. And that's fine. That's absolutely fine.
Yeah.
I'm just saying,
honest.
For me, if you got to ask us, what would I do if it was a family member? And we've seen so many issues with patients receiving radiation and getting implants that I would really strongly steer them away. If it was my family member, they wouldn't get an implant.
Okay, thank you.
That's how I feel about it. So
implants, reconstruction, no kind of reconstruction, or right?
No, just implants. No, it's for me, if you've had radiation, the best reconstruction by far is using your own tissue.
So I'm understanding what you're saying. So what you're saying is now is, if you want to rebuild, you're better off rebuilding with your own body parts than having to use implants, because the implants will be more dangerous. You would not advise anybody, but you would advise a family member to reconstruct with their own body, not to do the implants. That's what you're saying.
Yeah, well, in my opinion, a tissue there's nothing that beats reconstruction with your own tissue.
Okay, great.
In any situation, whether you've had radiation or not. But if you've had radiation, I would say really be careful of the implant choice, because your risk of problems down the line is much, much higher. So if it was my family member that had radiation, I would say don't do implants.
Doc, can I ask you a question?
You can ask me several.
Okay. I noticed, well, not everyone, not all women that I've known that have had breast reconstruction, but during my time of doing nursing, I've had some patients who did have breast surgery, breast enlargement surgery, right? And then when they start to age, I just want to know if it's true though. When they start to age, and I've seen a lot of women with no clothes on, we're taking care of them and everything like that, and we know what procedures they've had done. Okay, and when they start to age, you can see that it looks at least that they did have breast enlargement at one point, at one time, because then it dropped. It dropped. Is it true that you need to have that done every so many years? You have to have it, like boosted up or something, or does that happen to everybody, or does it happen to your patients?
It doesn't happen to everyone. It happens more to people that have had, let's say, in terms of a cosmetic augmentation, someone that just went in to be bigger, no cancer, just implants to be bigger. You know, if you become pregnant, you have children, you breastfeed, all those things increase the chances of you needing a touch-up, a lift, or something.
Oh, okay. So if you have the tissue implants, that's not going to happen. It's not going to just like when you start to age, you know.
No, the tissue flaps, as we call them, they just age with you, just like your normal breast would, your natural breast would. So.
Oh wow.
Okay, that's good. So you don't look, because it looks kind of funny when you're watching a woman in her 70s, and then you know that it's a possible chance that she did have a breast enlargement when she was younger, because it looks different from the way it would look if it was just natural.
Right.
I wanted to ask a question too, Doc. But when you do the surgery, do you have to go home with the drainage, the surgical drains?
Yep. It's not much fun, but you go home with several drains. Typically, you go home with a drain from wherever we took the tissue from, either the tummy, the thigh, or the buttock. You have a drain coming out of there, and then you have a drain coming out of each breast that was reconstructed. So if you have one breast reconstructed, you've got to expect to go home with at least 2 drains. If you have both breasts reconstructed, you're going to go home with at least 3 drains.
Right, because when I had my breast removed, I came home with a drain.
Yeah, you go through the whole thing again.
I gotta tell you, Doc, that grossed me out.
It grosses most people out. In fact, you know, it's the thing that most people. It's top of the list. That, you know, things I hated about my experience, drains. But unfortunately, it's a necessary evil. The problems we have by not using drains are a lot worse.
Okay. And I have to say, well, I had no problems, really and truly. People asked me if I, had pain. I had no pain. The doctors were really surprised because they gave me the morphine drip and told me during the night if I was in pain to just, press the button and get, use any of it at all, just what they gave me, and that was it. I never had any pains or anything. Now, after surgery, I would have a little discomfort and whatnot now, and sometimes I can't rest the material, the resting the prosthesis. I don't know if I'm allergic to it, and I use that silicone type, one, and I don't know, so that's why I was sort of, I was beginning to think about that, because it irritates.
Well, I was going to ask, too, about the pain, if there was pain after the breast reconstruction also, and how long does it last? Yep, there is pain.
All surgery is painful, whichever way you look at it, so.
You're right about that.
Yep, we've got great drugs, but they're not perfect, and it's the first day, especially after the surgery. It's not the best experience in the world, but we get our patients up out of bed and they're walking, and I've had patients. We have this list in the office that basically patients that want to do this, they sign up for it. They put their names down for new patients to contact. So, I was going about my business, and I'd had several patients that would say something about what they expected their recovery to be, and something was a little off. And finally I realized they were all talking to the same person from this patient list.
Wow.
Not to mention any names, Madeline. But this lady, 3 weeks after her DIEP flap procedure, she did 2 things that made me yell at her. Number 1, she was playing tennis, and number 2, she parked her car underneath a tree, and then apparently she was fearful that a branch from the tree would fall onto her car, so she climbed the tree.
Are you kidding me?
And sawed down the branch. Instead of just moving her car, that's what she did. So there are people that, now I'm not mentioning this because that's the norm, and I don't want you to think that's the norm, because it's not. All I'm saying is people do recover, But I'm also saying it because you've got to be prepared to take it easy. And doing those things at 3 weeks is something that's not recommended. So if you have a big tissue reconstruction, especially these microsurgical ones that we do, you're looking at 6 weeks off work.
Okay, and you ease back into work gradually.
Right, 6 weeks off work, and then at 6, it's like a marathon runner who breaks his leg.
Right.
Okay. 6 weeks later, the doc says, "Okay, your leg's healed." Well, he's not going to go out the next day and run a marathon. He's going to start training again. So, and that's exactly the same thing. We tell our patients 6 weeks before you can start to get back to what you were doing.
And what about lying on your stomach, being able to lie on your, like on your chest?
You missed that stuff. Yes.
Yeah, I don't know that anyone knows the right answer for that.
Oh. Okay.
We don't want patients lying on their bellies and lying on their reconstructed breasts for a while.
Right.
Let's say like a year later.
Oh, no, not that long. But
okay.
Yeah.
I guess, your body will tell you when it's time, because you'll know. It's with me, I had a bad vertigo after, because of side effects from the chemotherapy. And I knew that I couldn't spin around and whatnot, but one day something happened. I spun around and suddenly realized, I didn't fall. I didn't get lightheaded and get disoriented, and that's the point when I realized, well, okay, I'm okay. I'm not as bad as I once was with the vertigo thing. It was healing itself, so it was healing. I was getting better. So I guess it's the same type of thing with your breasts and stuff. You'd be careful. You take, because with myself, when I removed my breast, for a while I couldn't lie on my stomach.
Right.
Wow. And then, one day I don't even know what happened, but I could lie on my stomach, So I guess it comes with,
Well, you get to a point, too, that, you're doing more and more with each passing day, and you don't realize how much you're doing until you do something that hurts.
You're right. You're right about that.
So
like taking the train.
Right.
Like taking the train. Doc, what do you think about is it Christine Applegate?
Yeah.
The lady from Married with Children. What do you think about her decision to take both of them off because of what happened with her family? How do you feel about that?
Well, it's interesting. There's an article. Actually, I posted this on my blog. There's an article that talks about when is a prophylactic mastectomy, in other words, preventive mastectomy in the good breast, when is that a good idea? So you got cancer on one side, when should you take both of them off? And, the article, there's an article in the journal is Cancer, and it's actually called Cancer, and they looked at this. It's out of MD Anderson, and they basically said that it's a good idea to do this when the lady has a particularly aggressive or invasive breast cancer.
Right.
If the pathology results show that it's a kind of a high risk histology, something like in lobular. Whenever you hear lobular, that's generally not very good, because typically that means there's a higher risk of getting cancer on the other side.
Mm.
Okay.
Also, if you've had multiple tumors in the same breast, you should probably think about taking the other one, doing mastectomy in the other one too. And then they look at other stuff. They look at other stuff like age and family history, other medical history, their race, and all that kind of stuff.
Right, because they had a woman that she had her mother, her sisters had got breast cancer, so she didn't have it yet, but she was so scared. I remember reading an article a long time ago. She was so scared that she would get it that she had them cut off both of her breasts. Do you remember hearing that story before?
Oh,
she didn't have it.
Yeah, well, we see it all the time. I mean, and then nowadays you can get gene tested for the BRCA gene, because a lot of the time when there's a family history like this, multiple people in the same family have had it, sometimes it's because of a gene that's passed down.
Right.
And there's a BRCA1 gene and a BRCA2 gene. So if you get gene tested and you're positive for either of those two, you know that your risk is significantly higher, and that can make the decision a lot easier to make. Now, what I will say is that up to 10%, we think about 10% of women that have this gene test and are negative, those negative people, 10% of negative people, still carry some kind of gene. It's just that we don't know what to look for.
Oh, okay.
Oh, okay. So it's not like it's like the fear of getting it. They actually know that they have some type of gene that they could possibly get it.
Right. And
anyway.
then so you know, think of this scenario. Let's just say your sister has breast cancer, your mother had breast cancer, your grandmother had breast cancer. So you take this BRCA gene test, and it's negative.
Right.
Well, that doesn't mean you don't have a gene that increases your risk. Right. And in that situation, I think it's perfectly warranted if you want to have a mastectomy or have both breasts removed so that you don't get breast cancer in the future. I don't see how you can argue with that decision. Now, some people would say it's very aggressive, and they say, well, if you don't have breast cancer, why are you taking the breast off? But you can lay in bed at night driving yourself crazy, wondering what's going to happen.
Right?
Right.
So it's not. I don't think. I was reading this study that I mentioned before. And the bottom line, and again, I put this on my blog. For me, I think it's really important to remember what the patient wants. Right. And if a patient comes to you and says, "Look, doc, I called my insurance and they said I'm not a candidate for mastectomies, but this is driving me nuts, and they won't do it because I'm BRCA negative, but my mother died from it, my sister just got diagnosed, my aunt died of it, and I can't sleep at night, and I'm so fearful. I'm sure I'm going to get it. I want to have prophylactic mastectomies and reconstruction." That's good enough for me. How can you deny someone like in that situation?
Yeah. I hate to think we only have like 2 minutes to go, and Doc, I want to thank you for coming on the show, but I'd also like you to tell our listeners about your sites and so that they can come by and check it out.
Yeah, well, we've actually launched a new. Our group is called PRMA, Plastic Reconstructive and Microsurgical Associates, PRMA for short. So if you type in PRMA Plastic Surgery, will come up. The actual website is PRMA-enhance.com. Right. And then there's a blog on the site, but I also have another blog with a feeder too, so you can sign up and get updates, and that's breastcancerreconstruction.blogspot.com, and there's a dash between breast cancer and reconstruction, so it's breast-cancer-.
I read your blog.
You read it?
Oh yes, I do. I have it right. I usually print it out.
Oh, really?
Yes, Breast Reconstruction Surgery Center of Excellence.
There you go.
Mm-hmm.
Yeah.
It's wonderful.
I'm telling you, I've been tracking you.
You've been tracking.
And the website is just great. It's easy to access.
Yes.
You can click on information and get more information behind that. It's really great, and it has all your credentials on it. I love it.
Oh, well, thanks.
I would love to invite you to come back another time, and you can tell, so we can let folks know, and I will, provide a link to your site so people tell people about you. You can send us a little promo, and we will play it on the show.
That's right. Let us know when you're in New York so we can interview you for television, too, when you're in New York.
Oh, well, listen, my wife, I've been to New York several times, but I've never been with my wife, and the next time I go to New York, actually, we're talking about going to New York at some point. I have to take my wife to New York before, really mad.
Yes, definitely. Then you let Dillion know when you're coming, and we'd love to meet you up here.
Oh, that would be great.
Sure, we can shoot a show around you. Family, So we thank you very, very, very much.
Oh, you're more than welcome. Thank you so much.
And you have yourself, and I'll talk to you again. For coming, thank you, and thank you everyone for listening to DeLeon Dialogue. We'll see you next time. Been having a lot of problems, and that's the reason why I haven't been doing the show every week. But I'll keep you all posted so when the next is. Bye-bye, everyone, and one love.
Bye-bye. God bless you. Good night.
Stay healthy, and remember, do your breast self-exam. That breast you save might be your own.
Might be your own.
Right.
Bye.
Bye.
Bye-bye.